Welcome to the deep dive. Today we are undertaking, well, kind of a monumental task. We're unpacking the technical, physiological, and mechanical blueprint of human labor and birth, the whole intrapartum process.
Yeah, it's where biology really meets engineering, you could say. And honestly, it's one of the most intricate systems in the body.
Absolutely.
And we're wading through a lot of clinical material today. The goal is really to distill the core knowledge you need, from how the maternal body responds under, well, pretty intense duress, to the exact mechanical signs of normal progress and the trade-offs of modern interventions.
Right, that's the mission. We want to give you a clear, structured understanding of what defines normal labor, and crucially, why clinical intervention isn't necessarily a failure, but often, a needed course correction in a highly complex system. Let's unpack this, maybe starting with the sheer power of a uterine contraction and the surprising ways the body handles that force.
Okay. What's truly fascinating, I think, is the immediate and pretty dramatic effect a contraction has on the mother's cardiovascular system. Just try to picture the uterus as this huge muscle undergoing intense exercise. When it contracts, it pushes 300 to 500 milliliters of blood. That's like close to a pint directly back into the mother's general circulation.
Whoa, 300 to 500 milliliters.
Yeah.
Every contraction. That momentary blood shunt sounds like it would throw the entire system into chaos. What's the immediate measurable impact of that surge?
Well, you see two key shifts. First, there's a temporary spike in maternal blood pressure. Second, and this one's a bit counterintuitive, the heart rate actually slows down slightly.
Ah.
These rapid changes have huge clinical implications, which is why we always emphasize avoiding one specific position during active labor.
And that position is lying flat on the back, the supine position, right?
Yeah.
Why does that specifically mess things up when the blood dynamics are already fluctuating so wildly?
Yeah, exactly. Because the great vessels, the ones returning blood to the heart, get compressed when you lie flat. So if you're compressing those vessels while your body is also trying to manage this, 300 milliliter rush of blood during a contraction, you dramatically compromise that circulating volume.
Ah, okay.
Avoiding the supine position is just a critical safeguard against putting even more stress on the system.
That makes the connection between the mechanics and the physiology very clear. Now, beyond those immediate circulatory dynamics, what other major system shifts are happening inside the mother to get ready for birth? I'm thinking particularly about the blood components themselves.
We see some really striking hematopoietic changes. For instance, while a vaginal birth involves a normal blood loss, maybe up to 500 milliliters, the body prepares by ramping up its white blood cell count dramatically. We can see leukocytes, those are the main infection fighters, soar up to maybe 30,000 per cubic milliliter.
80,000? That high. That usually signals a severe bacterial infection.
Exactly. But in this context, it's simply a physiological response. It's a reaction to the massive physical stress of labor, not an infection. It's really just an indicator of the sheer workload the body is under.
Wow. Okay. Meanwhile, the digestive system, it seems like it basically throws in the towel. Gastric motility, the movement of the stomach and intestines, slows right down,
Yep.
which often causes nausea and vomiting, right?
Yeah, that's common.
This is where things get tricky regarding energy then.
It does. Because energy needs actually increase significantly during the sustained muscular effort of contractions, yet the GI system is essentially, like you said, shutting down. This leads to that classic clinical dilemma. Do you restrict eating and drinking to minimize the aspiration risk, which is real because of this slow emptying? Or do you allow maybe some light intake so the patient has the energy for what is basically a marathon?
Yeah.
That's a constant point of discussion in clinical care for sure.
And we also need to remember the urinary system. I read the sensation to urinate is often reduced during intense labor. But a full bladder isn't just uncomfortable, it's actually mechanically problematic.
Oh, definitely. It acts like a physical obstruction. A full bladder can literally prevent the fetus from descending properly into the pelvic inlet. It can slow or even stop progress. So frequent monitoring and sometimes catheterization become necessary just to ensure the passageway stays clear.
Okay, let's transition now to the other key player here, the fetus. How does this tiny body, the passenger, handle all that intermittent pressure and those brief periods where blood flow might be reduced?
Well, the fetal response is really a testament to biological resilience. We know placental blood flow dips sharply during a contraction, right?
Right.
But a healthy fetus usually has enough reserve capacity to tolerate this brief interruption. Why? Because the critical exchange of oxygen and nutrients happens efficiently in the moments between contractions when the uterus relaxes.
Okay, that makes sense. But here's where it gets really interesting, I think, regarding immediate prep for life outside the womb, the fetal lungs. They're filled with fluid in utero, aren't they? So how does labor actually prepare them for breathing air?
Yeah, the process of labor itself is instrumental here. The rhythmic forces of contractions, plus the squeeze through the birth canal, physically pushes fluid out of the baby's lungs. At the same time, there are chemical changes happening that speed up the absorption of any remaining fluid.
Mm.
So this mechanical and chemical clearing action ensures that when the baby takes that first vital breath, the tiny air sacs, the alveoli, are actually ready to open and function correctly. It's quite amazing.
And because the fetal cardiovascular system is so reactive to these pressures, we rely really heavily on monitoring its heart rate, don't we? Watching for those immediate changes, accelerations, decelerations, to make sure that reserve capacity isn't getting depleted.
Precisely. And that surveillance, that monitoring, brings us perfectly to the core framework clinicians use to understand if labor is progressing normally. The 5 UBs.
Okay, the 5 Ps. Let's unpack this clinical shorthand. It sounds like a structured way to assess if all the factors needed for a successful birth are lining up. Let's start with the engine, the driving force, powers.
Right. Powers are essentially twofold. First, you have the involuntary effort, uterine contractions. They need to be coordinated, involuntary, and crucially intermittent. There has to be rest in between. We assess them based on frequency, duration, and intensity. Second, you have the voluntary effort, the maternal pushing that really comes into play in the second stage of labor. If the powers aren't sufficient or maybe not coordinated, the whole system can stall.
Makes sense. Next P, passenger. That's the fetus itself. And it's not just about size, is it? It's about orientation and specific positioning.
Exactly. We look at presentation is the baby head first, which is cephalic, or bottom first, which is breech. Then there's fetal lie, which is basically the relationship of the long axis of the baby to the long axis of the mother. Is the baby lying vertically or transversely? But the most specific factor is fetal position. This is where a fixed reference point on the baby, like the occiput, the back of the head, relates to the 4 quadrants of the mother's pelvis.
Ah, okay. That's where we get those specific acronyms like LOA, left occiput anterior.
Right. So if the occiput, the back of the baby's head, is pointing toward the mother's front left side, that's generally a favorable position for birth. But if the occiput is posterior, facing the mother's spine, that can often prolong labor significantly because the fit through the passageway is just less efficient. It's a tighter squeeze.
The passageway, that's the physical anatomical challenge, isn't it? The actual route.
It is. It's the bony structures, the false pelvis, the true pelvic inlet, the mid-pelvis, and the outlet, plus all the soft tissues. It really is a tight, non-negotiable squeeze. And while the baby's head can mold slightly to fit, the actual type of pelvis the mother has, whether it's the typical gynecoid shape or maybe more android or anthropoid, can dramatically influence how easily the baby passes through.
Okay. And finally, the critical P that really separates labor mechanics from just pure physics. Psyche. The mind-body connection. This actually has measurable physical impacts, right?
Oh, absolutely. This is where emotions directly influence physical mechanics. We know anxiety and fear can amplify pain perception, making it harder to cope. But even more fundamentally, a tense, stressed, or scared patient might involuntarily tighten their pelvic floor muscles or restrict their own movement, which can physically slow down cervical changes and overall labor progress.
Wow. So the mother's emotional preparation, the support she gets, her sense of control, these aren't just like nice to haves. They actually translate into tangible physical outcomes that can speed up or slow down the whole process.
Exactly. The body is always listening to the mind, you could say.
Speaking of progress, how do we distinguish between the hard work that actually counts, true labor, and those practice runs that women often experience, sometimes called false labor?
The key defining line is cervical change. False labor, often called Braxton Hicks contractions, involves inconsistent contractions, maybe discomfort just in the lower abdomen or groin. And critically, there is no progressive change in cervical dilation or effacement, which is the thinning of the cervix. True labor, on the other hand, is consistent, it's regular, and it generally increases in intensity over time. The pain often starts in the lower back and kind of sweeps forward to the abdomen. And most importantly, it leads to that progressive cervical change we're measuring.
Got it. So once true labor is established, the timeline is usually mapped across 4 distinct stages. Can you walk us through those?
Sure. Stage 1 is the longest, It runs from the actual onset of true labor until the cervix is completely dilated at 10 centimeters. We typically break this down further into the latent phase, which goes from 0 to about 6 centimeters, often slower progress here, and then the active phase, where progress usually speeds up, running from roughly 7 centimeters to the full 10 centimeters.
Then you hit the dramatic action of stage 2.
Right. Stage 2 is the pushing phase, from full dilation until the baby is completely born. Stage 3 is usually pretty brief. It's from the baby's birth until the placenta separates and is delivered. If the stage goes much past 30 minutes, it starts to raise some clinical concerns about placental retention.
And stage 4 is the immediate aftermath, the recovery period.
That's the crucial recovery phase, typically the 1 to 4 hours immediately following delivery. The clinical team is intensely focused on surveillance during this time, mainly watching for any signs of postpartum hemorrhage.
We talked about how psyche can slow things down. What were some of the other key factors the sources highlighted that can potentially prolong labor or interrupt that smooth progression?
Yeah, several external and internal factors were mentioned. High body mass index, or BMI, is a recognized factor that can sometimes complicate things. Also, restricting the mother's movement unnecessarily. Movement can actually help with gravity and optimal fetal positioning. And certainly an uncomfortable environment, too noisy, too brightly lit, feeling constantly watched, that can activate that stress response we talked about, slowing things down. And circling back to what we discussed earlier, lack of adequate hydration and food, that energy depletion, is a documented barrier to efficient labor too.
Okay, that brings us perfectly to pain management. Our sources had, I thought, a really interesting philosophy here, suggesting the goal isn't just pain elimination, but managing the patient's overall experience.
Absolutely. The key insight, I think, is that the perception of the birth experience, whether someone views it positively or negatively afterward, is often more related to whether the mother felt she met her coping goals than the absolute amount of pain she felt. So if she felt supported, informed, and capable of handling the intensity, even if it was high, the outcome is often viewed more positively.
That makes sense. And that's why non-pharmacologic measures are so valuable then. They generally don't slow labor, and they don't have side effects for mom or baby. Things like therapeutic touch, hydrotherapy, like showering or bathing, using imagery, and that rhythmic light stroking on the abdomen known as effleurage.
Exactly. And simple breathing techniques can be incredibly effective. The sources mention slow-paced breathing, maybe aiming for like 6 to 9 breaths per minute. This actively counters the physical tension that anxiety can induce.
But if those non-pharmacologic measures aren't quite enough to meet those coping goals, the epidural is often considered the gold standard for providing the most complete pain relief.
It definitely offers substantial relief, usually has minimal direct effect on the fetus, and it's often the safest option for certain high-risk patients, like those with pre-existing cardiac conditions or diabetes. However, the trade-offs are significant and need to be considered.
What are those primary trade-offs that, listeners should be aware of?
Well, it can interfere with the sensation needed for effective pushing. This might prolong the second stage of labor, the pushing part, and potentially increase the need for instrumented deliveries, like using forceps or vacuum. Acute risks include sudden maternal hypotension. That's a potentially dangerous drop in blood pressure that can affect blood flow to the placenta, so that needs constant monitoring. And though less common, there's the risk of a severe post-dural puncture headache afterward.
Right, and it's also crucial to remember that systemic drugs medications like fentanyl or morphine, given intravenously, they will cross the placenta and can affect the fetus, causing things like respiratory depression at birth and general anesthesia. That's really reserved for emergencies only, isn't it?
Absolutely. General anesthesia carries the single greatest risk of aspiration, inhaling stomach contents for the mother. That's why it's reserved for the most urgent situations, like an emergency C-section where there's no time for an epidural. And if GA is induced, the clinical team is literally working against the clock. The fetus must be delivered ideally within 3 minutes of induction to minimize the drug exposure to the baby.
Okay, let's shift focus slightly to how the team keeps such close surveillance on the fetus during all this. We're constantly monitoring the fetal heart rate, or FHR, and the source has provided that fantastic little shorthand for interpreting what those patterns might mean. VL-CHAP-P. Can you break that down?
Yeah, VL-CHAP-P is basically the decoding key for FHR monitoring. It's a mnemonic. So if we see a V pattern on the monitor, that stands for variable deceleration. That typically corresponds to C, which means cord compression. The umbilical cord is likely being squeezed intermittently.
Okay, V is C. Then you have E and H.
Right. E stands for early deceleration. This usually signifies H, which is head compression. This pattern often mirrors the contraction and is generally considered benign. It's often just a sign the baby is descending and the head is pressing against the cervix or pelvis. Then A is acceleration, a reassuring increase in the heart rate, which corresponds to O, meaning oxygenation is likely excellent, or simply, okay, we like to see accelerations.
Got it. So VCEHAO. The most concerning pattern in this group is the L and P pairing, right?
Yes, L stands for late deceleration. This is the one that gets everyone's attention because it signifies P for placental insufficiency. This means the dip in heart rate starts after the peak of the contraction and recovers slowly. It suggests the disruption in blood flow during the contraction might be lasting too long, and the fetus isn't getting adequate oxygenation between contractions. This pattern usually prompts immediate intervention.
Okay, so if the FHR tracing isn't looking favorable, or if labor isn't starting or progressing, intervention might mean induction, getting labor started artificially.
Hmm?
When does induction become the recommended path, and how is its likelihood of success sort of judged?
Well, the success criteria often rely heavily on something called the Bishop score. It's essentially a readiness checklist that looks at the cervix, its dilation, effacement, consistency, position, and the baby's station. Generally, a score greater than 6 indicates the chances of a successful vaginal delivery after induction are much higher. The cervix is considered favorable.
And the actual methods used for induction.
If the cervix isn't favorable, we usually start with methods to ripen it first, make it softer and thinner. This might involve medications like misoprostol or mechanical methods like inserting a small balloon catheter, a Foley bulb, into the cervix. Once the cervix is deemed favorable, or if it was favorable to begin with, oxytocin, often known by the brand name Pitersin, is usually administered intravenously to stimulate contractions.
And the main risk of using Pitocin is closely tied back to our earlier discussion of powers, isn't it?
It is. The main risk is hyperstimulation, sometimes called tachysystole. This is when the contractions become too frequent, too strong, or last too long without enough rest in between. This dramatically increases the risk of those abnormal FHR patterns, particularly late decelerations, because it reduces the crucial resting time needed for placental blood flow and oxygen exchange. Careful titration is key.
Okay. Then, on the sort of far end of the intervention spectrum, we have cesarean sections, or C-sections. The national rate in the U.S. is around 32.9%, and it seems to be rising. Factors mentioned include increasing maternal age, higher rates of obesity, maybe the threat of litigation influencing decisions, and sometimes maternal request. What are the core risks associated with a C-section compared to vaginal birth?
For the mother, the main risks include increased blood loss or hemorrhage, higher risk of infection, potential injury to other organs, and longer recovery time compared to most vaginal births. For the baby, a common risk is something called transient tachypnea of the newborn. That's temporary, rapid breathing. It's often thought to be related to missing that full mechanical squeeze of a vaginal delivery, which helps clear fluid from the lungs. Though usually temporary, it can require monitoring.
Okay. Finally, we absolutely must highlight two rapid response emergencies that were detailed in the source material, situations requiring immediate specific action. Let's start with shoulder dystocia.
Yes, this is a true obstetric emergency. It happens when, after the baby's head delivers, one of the shoulders gets stuck behind the mother's pubic bone, preventing the rest of the body from delivering. The immediate and paramount rule of management is absolutely non-negotiable. Never apply fundal pressure. Pushing on the top of the uterus, the fundus, will only wedge the shoulder even tighter and can cause injury.
So if you can't push from the top, what immediate actions are taken to resolve it?
Immediate nursing and provider care involves specific maneuvers. Two key ones are the McRoberts maneuver, which involves hyperflexing the mother's legs sharply up toward her abdomen, changing the pelvic angle, and applying suprapubic pressure. That's direct pressure applied just above the pubic bone from the outside, trying to manually dislodge the impacted shoulder downward. Time is critical here.
Okay, McRoberts and suprapubic pressure, not fundal pressure. Got it. The second emergency is a prolapsed cord. What happens there?
This is another critical emergency. It's a scenario where the umbilical cord slips down into the vagina ahead of the baby's presenting part, usually the head. When this happens, the cord gets compressed between the baby and the mother's pelvis or cervix, immediately cutting off the baby's blood and oxygen supply.
That sounds incredibly urgent. What's the immediate treatment?
Treatment is all about relieving that pressure instantly. This usually involves immediately repositioning the mother, often into a Trendelenburg, head down, or knee chest position, to use gravity to help take pressure off the cord. Simultaneously, the clinician, often a nurse or midwife who discovers it, must manually insert fingers into the vagina to physically lift and hold the presenting part off the cord, maintaining that lift while everyone rushes toward an immediate emergency C-section. You cannot remove your hand until the baby is delivered.
Wow. Okay, that is intense. So, wrapping this deep dive up, what's the ultimate takeaway from this really intricate blueprint? We've seen this incredible choreography, haven't we? Between involuntary physiological events like that dramatic blood shunting, the raw power of the uterus, the way the fetal lungs clear themselves, and then these mechanical factors, the 5 Ps, which are surprisingly sensitive to environmental and even emotional influences.
Yeah, I think the synthesis for you, the listener, is that the intrapartum process is truly a system operating at maximum capacity. It's balancing immense power with delicate precision. The body is remarkably built to manage it, but its inherent vulnerability, the potential for things to go off track, is exactly what necessitates that constant clinical vigilance and the structured responses we've discussed.
That's a great way to put it. And as you reflect on that dynamic balance between the body's power and its vulnerability, we want to leave you with one final thought to ponder.
Yeah, consider this. We noted how those powerful contractions temporarily cut off placental blood flow, meaning the fetus has to rely on its built-in reserve capacity. At the exact same time, the mother's cardiovascular system is managing that huge shunt of blood, hundreds of milliliters, back into her circulation with every single squeeze. So, considering those simultaneous significant stresses, which specific biological phenomenon do you think is perhaps the single most critical protective mechanism ensuring fetal well-being during the intense journey of labor? Is it the maternal ability to rapidly manage that blood volume shift, or is it the fetus's inherent physiological reserve to tolerate those brief dips in oxygen? Something for you to perhaps explore further on your own.